So you're joining the Fireside Chat. This is a conversation with ARISTA MD, and we're going to be talking about telehealth, particularly eConsults. So we'll give folks just a couple more minutes to join. Okay. So I'm going to get started. And then as folks join in, we'll continue to march, and I will talk a little bit. First, I want to make sure we level set about the program, and then I will introduce you to our panelists. From there, we'll talk about your ability to ask questions today, to participate, use the chat, and then from there, we'll go into our discussion. So I want to thank all of you for joining us this morning. As most of you are aware, in the next 2 days for this conference, we'll be focusing on telehealth trends. And telehealth services have really seen widespread adoption as a result of the COVID-19 pandemic. And they offer very viable care delivery solutions when patients are unable to access care in a traditional face-to-face setting. I want to level set by just introducing myself. My name is Pam Gould. I'm a registered nurse by background. Actually worked many years in nursing before transitioning to the business development place, and I'm now the Chief Growth Officer here at ARISTA MD. I will also introduce our panelists in a second, but wanted to talk a little bit more about what we will be discussing. So we know, as I mentioned earlier, that telehealth is a trend that's here for the long term. And post-pandemic, we do anticipate that patients, now that they've experienced the access and convenience of telehealth, they're going to want these types of services going forward. We expect that they will only grow as patients want more and more to be met where they are. So for this session, we're going to home in on asynchronous telehealth offering known as eConsults. And unlike traditional urgent telehealth, whereby patients contact physicians directly to aid with a health problem, eConsults connect primary care providers to specialist physicians using a secure technology. And just to level set, there's 2 types of eConsults: formal, where patient PHI is exchanged over a secure platform, and a specialist physician will recommend a plan of care. And then there's informal or curbside eConsults, where there's no PHI exchange, but rather an exchange between providers designed to confirm a plan of treatment. For this discussion, we're going to be focusing on formal eConsults and how they've supported the organizations our panelists represent. So I'm very fortunate to be joined today by some incredibly talented and forward-thinking individuals. I will ask our panelists to introduce themselves in just a second. However, did want to share with the audience that 2 of our panelists oversee medical care within WellBe Health, which is an incredibly innovative PACE program. And one of our panelists is the Chief Medical Officer from Lean Healthcare, which is a Fortune 500 company that's focused exclusively on government-sponsored healthcare programs. So we're very excited to have their collective expertise on our panel, and I'm going to ask them to introduce themselves and share a little bit more about their roles, particularly related to the oversight that they have for telehealth and eConsult initiatives within their organizations. So Alexa, will you start us off?
I'd be happy to. Good morning, everybody, or afternoon, depending on where you are. I'm Alexa Grant, Network Director for WellBe Health. In my role at WellBe, I oversee the provider and partner networks that we build on behalf of all of our PACE programs. A little bit of background is, from my side, is I have a background in public health and have participated in value-based care settings and organizations in the digital healthcare space as well. It's a pleasure to be here. Thank you for having me,
Alexa. Dr. Robinson.
Yeah, thank you for welcoming me and having us on the panel from WellBe Health. So yeah, my name is Colin Robinson. I'm a medical director here at WellBe Health, specifically the Pacific PACE site. So that's in Pasadena, California. I actually have a kind of a longer experience with eConsults, even dating back before working with ARISTA MD. I used to spend some of my time at LA County as well, but specifically at WellBe Health, I've been involved actually a lot with Alexa in kind of working on and optimizing our eConsults. I work with training our providers on how to do it. We collaborate on that. and then just kind of building, working on our relationship with eConsult provider like ARISTA MD. And I'm a very strong proponent of it. We can go into more why later, but that's a lot of my role. Part of it, I guess, is reminding providers, continuing to say, okay, we need to think about it in a different way. How do we do consults in a new kind of more, quicker and more modern fashion? So that's my role.
Terrific. Thank you. And Dr. Khan.
Hi, good morning. My name is Saeed Khan. I am the Chief Medical Officer of Molina Healthcare of California. Molina is a multi-state health plan that primarily supports and provides healthcare to government-sponsored individuals. We have almost 4 million members nationally. My background is I'm an internist. I practice as a hospitalist, however, at the local VA in Long Beach. I've been in Southern California most of my career, and I've worked with several of the large IPAs. And in regard to eConsult, I'm very excited to be able to bring the perspective of the payer on how this could look. I think there's really been two perspectives, and so interested in sharing that with the group through this hour. Thank you.
Thank you. So we will have questions from, there's a little bit of a background. Robbie, can you help us with that? Okay. So we will have questions from 5 categories, including care delivery challenges, how the pandemic has impacted our care delivery, specialty access, telehealth, e-consults, and then cost savings. What I'm going to do as we answer these questions is strive to dedicate 5 minutes to each question. I'm going to ask all of our panelists to comment on each question. And my desire, again, is to keep this conversation fluid. So we'll often ask each of you to provide additional commentary as we're conversing. I will also take comments and questions from our virtual audience after each discussion round to really further guide our conversation as a whole. So please note you'll be able to ask questions directly to our panelists during this conversation, or if you prefer, you can use the chat feature provided in the Zoom forum, and we will be checking that after each round of questions that we ask. So we'll have a few minutes at the end where we're going to leave time for questions and give our panelists an opportunity to summarize some of the key ideas they've shared and any of their parting thoughts. So are there any questions before we begin? Okay, so our first question is general, and it should help to kick off our conversation. So in regards to telehealth synergy, what I want to ask is, what are some of the care delivery challenges as panelists that you are experiencing in your market? And I'd like to start off with Dr. Khan answering that question. Dr. Khan?
Great, thank you. In the space that we occupy, one of our biggest challenges is because we are in Medicaid, is access and availability. I think in all the states that we serve, and probably regardless of where you're at, access has become incredibly more difficult, particularly during COVID. But even prior to COVID, access was a challenge. We have membership, patients who live in very rural areas. There is a big part of America that lives in rural areas. Not everybody has a clinic. In some of these areas, you don't have a specialist that is within, half an hour of driving distance, et cetera. They may be driving hours and hours. And then to be frank, they may be driving hours and hours and get to a specialist, spend another hour waiting, have a 15-minute visit and go, that's it. That's what I spent my entire day to get. So, the biggest challenge and the biggest opportunity is to fill that hole of being able to bring specialty care to the primary care office. And from our perspective, the health plan's role in helping to support that is a big deal. It is not necessarily always officially, doesn't always officially count as for access per se. I think we're definitely working on eConsult being a reasonable alternative in certain circumstances to becoming a reasonable alternative to a face-to-face visit. COVID, I would say, has definitely brought that to the forefront, where that conversation is more relevant today than it ever was before. But I would say the biggest challenge is access and availability, and the ability to get specialty care to patients, to members, quickly and efficiently wherever they are at.
Great. Thank you, Dr. Khan. Alexa, did you want to comment? I know you're in a little bit of a different environment, and maybe could speak to some of the nuances. I'm sure there's a lot of similarities to what Dr. Khan was saying in a PACE program.
Mm-hmm. Definitely, yeah. Happy to comment, and thank you. Very much agree with Dr. Khan. We experience similar challenges around access and availability. Access being a couple of different things for us. Many of our folks in our PACE population do come from dual backgrounds, but they're typically high acuity, pretty vulnerable elderly population. So access can be a lack of a certain specialty within some of our service area, but it can also mean long wait times to be scheduled, even if there are many specialists in a given service area for us. So we do grapple with both of those challenges. And one of the important things for PACE programs is the collaboration with specialists for our PACE team. And so when we are working with our network of providers, we rely on them and their expertise and the collaboration on receiving back consult notes timely, having them be participants within our care planning process. And so because of these panel challenges right now in the pandemic, where you have additional closures, you have very busy panels where it's hard to be seen timely, we are lacking some of that collaboration as well. And so that is another challenge we're seeing with our partner networks, is they're busy trying to serve what they can given the pandemic time, but that collaboration that's so key to the PACE program may also be lacking as well for us. And that's something where I think the eConsult can really support, in that it's very fast feedback from the specialists that we're working with, and feedback that actually directly contributes to the care planning process and the collaboration that's required around the care planning process for our PACE participants, which is our word for patient.
Got it. Okay, excellent. Thank you for that.
Absolutely.
And then Dr. Robinson, is there anything else that you would add to what Alexa said, or with Dr. Khan, just kind of piling on, if you will, to the benefits of eConsults?
Yeah, so a couple of points that worth echoing and kind of taking a slightly different tack. So at our PACE centers, so we have 4 in California, and they're centered in urban environments, although people don't all live in the city per se. But having again practiced in both Pasadena, county, different areas around the city, the urban access, the fact that people have to take a full half day off or a full day of work off, even if it's only a half-hour drive, right, in the best of times in LA, for example, you end up missing an entire day. So that's someone who's if working poor or just struggling financially, which is a lot of people, and not just California but nationwide. So you end up missing an entire day's worth of wages just to go to a consult that's 30 minutes away, halfway across Los Angeles, which doesn't seem that far. So it's ironically a very similar struggle. If you're in Montana and you have to drive 4 or 5 hours, which is a reality, that's kind of hard to match in LA. But the couple hours that you do have to spend, that is kind of similar. And then the partnership is crucial, because PACE is a kind of a unique model. When you have a specialist, for example, that's more along the fee-for-service line of thought, that's how they're typically aligned. They're not as accustomed to sending notes. They're not as accustomed to communication, building relationships with our interdisciplinary team, building the care plans, or thinking about utilization, period. And that's something that we can delve into, because there's a huge difference between that type of consultant, the brick and mortar, versus an e-consultant who's already oriented a little bit more towards, okay, well, how can we actually do this in a more reasonable, fiscally responsible, but still of the appropriate standard of care for our patients or participants. So we can go into that a little bit more, but that alignment is really, really important for organizations like PACE, like managed health plans.
I like that. That's a very good point. Thank you for that. And then I noticed a couple of some really great points that you all made. But I think probably top of mind, one of the ones I want to focus in on, and then I do want to go back to utilization, because I think that that's a very key point, is really the mindset of the specialist that's answering the eConsult. Great point, Dr. Robinson. So when we're thinking about right now in the COVID pandemic, and we're all hoping that this is something that's in our rearview mirrors shortly. But as we're thinking about this and kind of this new normal, can you provide some examples of how eConsults have really helped maybe during this time? Maybe dive a little bit deeper on utilization. Dr. Khan, you talked about access issues that existed prior to COVID. We know about that with specialist shortages, but are there things like furloughs as hospitals are kind of closing down? Are we seeing that this is creating even more of a strain on that access concern, and then how the eConsults are helping with that? So I'm thinking, Dr. Robinson, would you like to start us off on that question?
Yeah, absolutely. This is, for nobody in healthcare has this been a normal time, right? This has been probably the most difficult time for most people working in American medicine, probably in our careers. And so it's changed everything. So we've had tremendous backlogs at just big providers, big groups that we've been working with that would just not see non-urgent consults. And non-urgent to an institution, I get the difference, right? In an institution, it's non-urgent to them, but the participant or patient is wondering, well, when am I going to get this, this thing addressed, whatever this thing is, a mole, a heart failure question, whatever it may be. So we would see people routinely with, closed clinics for 2 months, and then a backlog from there. So to get someone in to be examined and seen and a good recommendation sent back to us, we're talking about 4 to 5 months potentially, if not never, right? So which has happened for sure. We've just decided to say, okay, we'll close this one out and go with an eConsult and take it from there. So that has definitely very much changed our workflow. I think it's pushed some of our providers to use eConsults a little bit more as well. And I would say another point, just more from the clinical side, is as people are not able to bring others in. So we deal with an elderly population, right, which is a huge component of healthcare writ large in America, right? It's not just PACE. We specialize in that, but it's not just us. A lot of what we need is someone who's there to give collateral information to the specialists who might have a little bit better of a sense of what's going on with the healthcare, what's going on with the history, what the behaviors of that person might be like. And so if the participant who might not have, their sharpest cognitive status anymore is going by themselves, right? They can get to and from themselves, but they can't give a great clinical history. Then you end up getting kind of inaccurate or unhelpful responses. And I can try to give the best information that I can in the consult referral order, but they're probably not going to read it very well to take all that information in. And so you end up getting these really incomplete notes, and it comes back to you and you're kind of disappointed, saying, well, I could have done this myself and just taken a shot at it if I just really wanted to do it this way. So there's a lot of that information transfer that's actually been lost in COVID as well when you're trying to do things face to face. And I would imagine this is not just for elderly patient populations, but especially so in elderly patient populations.
Wow, very interesting. Thank you for that. Dr. Khan, what are your thoughts on this?
So, I agree with Dr. Robinson's comments. Maybe I'll start off with at the health plan, or at least in managed care, we're typically dealing with overutilization and trying to kind of steer towards more value-based care. This is probably the first time in many of our careers that we're dealing with underutilization, and it's absolutely a function of COVID. And to Dr. Robinson's point, earlier in the year, we essentially saw clinics shut down. Private practices, large groups, they were shut down for quite a while. So to some extent, it didn't matter what type of electronic delivery mechanism you had, the clinic was shut down, and there weren't going to be any consults, albeit whether they were going to be in person or they were going to be electronically. What we did see, and so we did see a drop off both in e-consults and in face-to-face type of visits. But what happened is once the clinic started to reopen, those that were positioned with having an e-consult solution essentially rebound quicker in being able to offer specialty care to their patients faster than somebody who is a clinic that was sending traditional consults. And I think that's noticeable. I think in that, when we talk about utilization and value, and I'm sure this will come up in later questions, is really talking about the value proposition, because there's a value proposition for eConsult, whether you're talking about managed care, there's a value proposition even in fee for service. But with regard to what we have seen in the context of COVID, those who were already deploying an eConsult solution were able to quickly bounce back and continue that. I think the biggest challenge is getting the word out. As you mentioned in your opening, there's just a lot of providers out in the community nationally who are just uncertain about what exactly is an eConsult, who pays for it, how does it all work, and then I always get questions about, well, what's my liability as a primary care physician? What would my liability be if I did an eConsult as opposed to send it? So those are some of the things that come up.
Very interesting. Thank you. Alexa, anything to add on to what Dr. Robinson and Dr. Khan have said, particularly around utilization? I want to go back to, and I'm actually making a point of going back to the liability piece, because I think that's something we should flesh out a little bit more. But what are your thoughts as far as what you're seeing during COVID-19, the way that people are rebounding, to Dr. Khan's point?
Absolutely. Yes. Thank you. And I think both framed it wonderfully. And, Dr. Robinson spoke about, some of the scheduling delays. And of course, our participants being quite acute in a lot of circumstances, those scheduling delays, are just not an option under majority of the scenarios. And so I think eConsult allows for us to get that access in a sooner manner. When you're seeing these closures happen, a lot of times because of the vulnerability and the risk of our population, folks would say to us, our provider partners would say, we cannot have an elderly population come into the office. It is too risky. So we were sort of the first to see the shutdowns and the long lasting timeline around that, because there is a tail end given the risk of our population. And so from a utilization perspective, if you think about a PACE program, we are on the hook for transportation for our participants. And so if you think about an eConsult where you're able to get that feedback quickly, get that expertise quickly without that additional cost of transporting the individual, that's a huge win. And on top of that, if you are thinking about consults in the external community, going to a brick and mortar, typically you'll go for a consult, but there are also follow-ups and diagnostics that happen thereafter. And so the value of an eConsult is far beyond just a one-to-one eConsult versus an external consult. It actually is more of an accumulation of around that entire continuum of care. And that's where you see the true utilization value, especially again, from a PACE perspective, where we are on the hook for transportation in addition to the cost of all of our external provider care.
Great. Thank you, Alexa. And it's funny you should say that, because as we look at the literature, one of the things we found as an organization is that typically for every one of the eConsults we do, we're avoiding 3 specialty visits. To your point, the first one being the testing, the second one being the evaluation, the third being, let me evaluate the evaluation of the treatment plan. So yeah, very, very good point. I want to stop right now and just open it up to the audience. Doug, do we have any questions on chat?
No questions so far.
Okay, and are there any questions from our audience regarding the last 2 topics that we've discussed? Bright and early in the morning for people. So.
One thing that I might add to Alexa's last point just now is that it was the repetition of testing that we often see. So in addition to the repeated, follow-up appointments, she and I have gone through this numerous times, like how many do we think actually happen per consult that we send to ARISTA MD, or any consult service. We happen to use ARISTA MD, but in addition, I'll have an echo from 2 months ago, right? 3 months ago, and I send it over and it goes in the packet, right? But in American medicine, it doesn't really quite smoothly transfer to the specialist in the brick and mortar. So they'll often order the echo. They might even do it like in the clinic themselves. So you end up getting an echo that was completely unnecessary. And that's just an example, but that's one of many tests that I've seen repeated unnecessarily just from having sent someone to a brick and mortar consult. So we have to keep close tabs on that, and we try to communicate, but we can't guarantee that person's actually getting the communication, spending the time with it, and with all empathy to my specialist colleagues, because I have a lot of very close friends who are specialists too. They have a lot of information to run through. They have a lot to work with. They have a very busy schedule as well. So it's hard for them to dig through, 40 sheets of paper to find that echo that was done 2 months ago behind a couple notes and some labs and some face sheets and all of that. So this could really obviate, that whole confusion there.
Thank you, Dr. Robinson. And do you feel, given your comments on that, we're all looking at, some of the folks on the call are in value-based arrangements or looking at quality measures, looking at how this has impacted that. Are you seeing that there's a positive impact, certainly with cost, because we've already talked about just the ability to decrease transportation, decrease, X number of visits. But what about quality? Are you seeing any impacts there?
That's great. We actually haven't built any metrics to look at quality in terms of that. Alexa, I saw you took the mic off. Did you have anything to add off the bat?
Go ahead, Colin, and then I'll
my answer is that from the clinician's perspective, it definitely feels like the quality is up. The communication is a little bit clearer. The question is being answered the way I've asked the question in the first place, not just here's a person with a neurological problem, go. It's more, here's a person with Parkinson's. And I'm wondering if the specific question around their Parkinson's, this medication, should I increase it? Should I decrease it? Is this manifestation related to it? Period. And that's it, as opposed to a huge array of questions that they kind of, and in all good intention, make up for themselves because they see a problem and they want to address the problem. And that's totally understandable. But so when you're able to narrow in on that question and give that to somebody, provide the specific data that you want to provide to them, they're able to give you a better answer relating to that. And obviously if they read from that information, the question, oh no, this person for their Parkinson's, for example, does need to be seen because that neurologist might need to monitor their tremor over time, sure, right? Or something like that. Then that, but at least you get the right question answered.
That's great. Alexa?
Yeah, just to build on that, I think as a PACE organization, us being able to work with eConsult and the eConsult specialist empowers our mid-levels to control quality a little bit more as they deliver care in the primary care setting, which is huge. And it's a wonderful thing. And so to Colin's point around, yes, we haven't necessarily built those measures internally yet. We are on the hook regulatorily for access and timeliness of access and scheduling access for our participants. And of course, anywhere where we can build in more robust controls for our care team to deliver recommendations in the primary care setting where we know the abilities and the quality level of our practitioners delivering that care is going to be high is a special thing. And I do think the eConsults allow us to do that from a quality perspective.
Fabulous. And Dr. Khan, before I move on, did you have any additional thoughts on, empowering providers? You had said earlier, giving them access to these tools to really enable providers to have more tools, if you will, in their toolbox. Do you see this also as a way of helping to improve quality?
Yeah, I share Dr. Robinson's comment, which is, off the top of my head, we don't necessarily have KPIs that I can comment on, but there were two important points made. The first one is the impact on or the resource that this creates for an advanced practice clinician, nurse practitioners, et cetera. And then the second is really driving this through a clinical leadership perspective. As Dr. Robinson was commenting, you have to want this as an organization, and this being defined as you have to want to be able to get to a diagnosis and a treatment plan quickly and efficiently. And if that's not part of the culture of the organization, then it's a difficult thing to adopt. eConsults, it's probably not going to be culturally the right fit. I had the pleasure of leading a medical management department at a large FQ in LA. And that was one of the biggest issues to tackle. And we did tackle it, which was prior to coming to Molina, was getting the providers, getting the docs and the advanced practice clinicians on the front line to say, you can do this yourself for many of these diagnoses. If given some direction with a focused question, and that's key. It can't just be, I hear a heart beating, tell me what's going on. It has to be a very specific question on, do you think this is atrial fibrillation, the EKG is a little off, or how should I titrate the rate control medication? Or do you think I should anticoagulate this patient, just using AFib as an example? Really provides a lot of resource to a clinician, but they want to have to do it, meaning you have to create the right incentive, create the right culture to keep that care as much as reasonably possible and safe at the primary care level. So I think it's critical. That goes without saying. You just can't force this. You have to drive it through clinical leadership, is my opinion. And two, it really does provide a lot of resource for advanced practice clinicians. You don't necessarily have them feeling like, oh my gosh, what am I supposed to do when I need a specialty consult? They have an alternative resource before they just kind of send it off to as a specialty consult.
That's a great point. And Doug, did we have questions?
Yes, Pam, there is a question from Rick. So Rick asks, are these consults designed to be one and done or ongoing e-consults with a specialist? And then, or are you taking their advice and then continuing to manage yourself as the PCP?
Okay, so it sounds like there's two parts to the question. So are these e-consults designed to be one and done? The answer is yes, they are designed to be one and done, but I'd like to take this back to our panelists and have them respond on their experience with e-consults. Is that what they are seeing? And let me start with Dr. Khan. Yeah,
I think that the short answer is they can be both. Depending on what the specialty is and depending on what the question is, it may be something as simple as a dermatology consult where there's a photograph attached with it. Is what is this diagnosis? I think it's this. Do you agree? And the answer will be yes, and you move on. It's not life-threatening. It may be something fairly simple. In the more complicated e-consults, there may be a couple of back and forths, which ultimately may result in, I think this patient needs to go and have a face-to-face evaluation with the specialist. Or it could be something as simple as, I'm considering titrating this medication up or down. What do you think? And then it's done. So it really does depend on the clinical scenario. It's unlikely to be multiple back and forths. At that point, you kind of have to raise the question, maybe this does deserve a face-to-face. So I'd say most of them are one and done. Some of them can be a couple of back and forths, and then the situation either resolves itself or results in a face-to-face.
Hey, Dr. Khan, this is Rick from South Carolina.
Yes.
Hey, Rick.
So if you are going back and forth and then you say, okay, I really believe this person needs to be face-to-face, hands laid on them, it would not be this same specialist, right? Or are they pairing you with a specialist in your vicinity? Because otherwise you're just going and starting all over again with another sub.
So it's a great question, Rick. So the way ARISTA MD designs our e-consults is that when you do request an e-consult, we keep an open line of communication that's ongoing between the requester, who is the provider, that can be a physician or nurse practitioner, to our panelist points, and our specialist who is answering that e-consult. So that is consistency of care, and it allows them to go back and forth as many times as they need to obviously come up with a resolution for that member's care.
Right, but if they need to see somebody, is the specialist that you're communicating with, if say they're in Barnwell, South Carolina, right? So you're talking about rural, and I'm in Charleston, and I sit there and say, okay, well, and I mean, of course, we have all our specialists there, but just say I didn't, right? And we were communicating, and then I got an e-consult, and that doc was out of New York. Or are you finding somebody that is in a drivable range for that patient so that if they actually do need to follow up face-to-face, they can go to that person's office versus having to start all over again with a specialist within their driving range is really my question.
Yeah. So I'll answer this and then I'll turn it over to my panelists. But so a very good point, Rick. So what we do at ARISTA MD is a couple of things. So we do have our panel of specialists. We have over 200 specialists, 70 different specialty areas, where you can do an e-consult with our specialist. And then if you should need to go forward to your point, you might see someone different, but our specialist would make recommendations to stabilize a patient in the time that they're waiting to go forward for that face-to-face. We also have a second solution, as part of our overall eConsult strategy, which is we can have a local panel of specialists using ARISTA MD. So if you are in South Carolina, we can have panelists in South Carolina answering these eConsults as a primary tool. They then respond to the eConsults, and if they're in the network where this patient is being seen and they need to move forward with a face-to-face, we've already established some of that relationship going forward with the eConsult, and they would see the same specialist. So we have two options on our platform.
And is this just because this is, I got an email from somebody named Glenn that said that Saeed was on this and invited me to join. So I don't really know much about it, but so eConsult is not a face-to-face with the provider and the member in the room. This is like basically the provider doctors up a description, labs, and sends it, and then the specialist does it at their leisure and then responds. Is that how it works?
Correct. It is asynchronous. So that is what's happening. It's peer-to-peer. So it's provider, the primary care physician, the nurse practitioner to the specialist.
Okay. Thanks.
You're welcome. Great questions. And anything that our panelists would add to that?
I think a couple of points there. That's a great question, Rick. That's because it does get into that kind of the nuts and bolts of what happens afterwards. I think from the PACE organization, we're constantly trying to curate our network and get the providers that we want to work with, who are the brick and mortar providers, such that, and it's an imperfect practice at this point, but we get the answer from the e-consultant, and they recommend X, Y, and Z study or in-person consult. Then hopefully we can communicate to the specialist, hey, Dr. Smith, this is what was recommended. I've done this so far. Please give me the answer. Now, it might be a little bit of a roll of the dice whether they're going to read it every single time, but that's definitely hopefully we can at least get the prelim information done at least to them that way, one way or another, either in paper or verbal format. So that's one way we try to work around it a little bit as well.
Thanks, Dr. Robinson.
Pam, there is one other question.
Okay.
Can the provider speak to the liability issue of e-consults versus sending out for eval and treat?
Yeah. So, and I will default to my panelists after I'm going to answer this as well. So the liability for the e-consult will always remain with the person who is doing the ordering of whatever the care treatment plan is. So that's going to be with the primary care provider, the nurse practitioner, or whomever. However, most of your eConsult organizations, and I'm kind of doing this as a global, I can tell you that ARISTA MD does this. We are going through a very rigorous licensing process with our physician panels and all of our panelists. We do NCQA accreditation. There's a very robust vetting process they go through, background checking, training. And then we also have a QA that we maintain on our platform where all of our providers are able to rate our clinicians on a score of 1 to 5 stars. And based on that rating, we're able to tell if our respondents and our specialists are really providing the type of care and care delivery that we expect and what our standard is. If we see that we have low scores, we're going to do some re-education, some retraining. If they continue to be low, we're going to remove these folks from the panel, assuming that they're just not a good fit. So there's a lot of things that we are doing to maintain very quality and very robust care. It also goes without saying that as we're vetting our panelists, we're looking for practitioners who have, specialists that have about 15 years of training. They're all board certified. And many of them are coming from very prestigious organizations, hospital settings, as well as universities. Anything that my panelists would add on that as to what you've seen with quality and or, questions that you would want to, or the question about liability, anything that you would add in that you've seen?
Okay, maybe I'll add my experience. I spent more time on the provider side than I have on the health plan side, so I'll put my provider hat on. I think when it comes to liability, one of the biggest questions is from the primary care physician or the referrer is what would my liability be if I sent this as an e-consult as opposed to if I sent this referral for a face-to-face? That's typically the question around liability. And if you're a clinical leader in your organization, that's probably what you're going to get first from the docs or the providers in your organization. My response to that has always been the same. We've been doing this for a long time. We have been doing unofficial e-consults for a very long time. They're historically known as curbsides, right? And everybody has different varying levels of how they do that and tolerating risk. These are not unofficial curbside consultations. There's documentation involved. There's a formality as far as there's a minimum data set that needs to be included. If you're going to be asking a question, there has to be some supporting information. It's traceable, it's trackable. And at the end of the day, it really comes down to how much of the care do you feel comfortable keeping under your own purview as a primary care physician? So again, I'll go back to it really does get driven by the clinical leadership, and that tone gets set. What is within the purview? As an example, again, from my provider experience, was the #1 specialty referral that was occurring in a past life was dermatology referrals for acne. Dermatology referrals for acne. It took a lot of digging to figure that out. But in general, that would be considered under the purview of a primary care physician. So eConsult very quickly solved that, because the question was, do you feel comfortable managing acne as a PCP? Yes, I do. Well, okay, we have a resource for you that can give you, option B, C, D, E, F without then formally having to send them out. And so I think it still comes back to having that conversation, setting the culture, setting the tone within the organization of what the tolerance is to that, and at what point it becomes a risk and you really do have to then send out. And lastly, my experience has been, if the specialist on the other side of the eConsult feels this really does need a face-to-face, they will tell you it needs a face-to-face. They're not going to try to keep the consult as an e-consult. They'll say, you need to send this patient right away, either to the ER or send them right away to a face-to-face visit.
That's extremely helpful. Thank you, Dr. Khan.
Yeah, and to add to that, I think it really should be emphasized that not just from the liability perspective, but from the just utility of e-consults. I think no matter what, you really need to have your providers trained in how to do it. Not just the mechanics of putting in, in the website or whatever it may be, or the order set in your EHR, but it really is about how do you ask the question? How do you maybe look up the information first so you can get the right information, so you don't just send someone, an e-consult that's, oh, I'm wondering if this person has rheumatoid arthritis. Well, okay, well, did you do any of the labs for that? Because they're just going to tell you to do the labs, right? Because that's important for diagnosis anyway.
Sure.
And, that sick, not sick determination that we all have to do as providers is really important in just our foundational training. And so it's really important to also, hammer into your discussions about e-consults. Is this something that really needs to be done in person because you're really worried about how sick this person could be, consequent to this disease process, whatever may be going on. And that may require, for fresher providers or mid-level providers who don't have as much experience in this area, kind of a little more discussion, a little more coaching through that process early on. And then as they get more comfortable with it, then you can, lengthen out the time between those sorts of discussions with your providers. And so that's an important component of it, kind of no matter what, is making sure that they're trained, the culture is there, they can ask you as a, say a clinician leader in the organization, is this appropriate or not? What can I do in this situation? I think that's going to be crucial no matter what. That'll get to better utilization. That'll get to better, clinical responses. That'll get to better liability protection. Is asking the right questions with the right information and the right lens.
Agreed. Absolutely agreed. Thank you. Okay, it looks like we have a few more questions. Doug, am I right?
Mostly chats about sharing questions, some asking about the recording. Oh, here's another question. What is the turnaround time a provider would expect from the specialist once an e-consult is initiated?
Okay, I can take that one. So if you're working with ARISTA MD, our SLAs are basically 24 hours from the time of request, but I can tell you that our average time is anywhere from 5 to 7 hours. Actually, we've seen recently this month, as we were auditing how quickly the eConsults were turning around, we're averaging about 4 hours. So they're relatively quick. And the nice thing about, again, the eConsult being asynchronous is it's allowing the provider to look at that and be able to review that in the time element that works for them. Any other questions?
No, that has us all caught up on questions.
Okay, excellent. Thank you, Doug. So I wanted to just tee up one more question, and I think given the time, this may be our last one, but we'll certainly continue to, if we can ask a few more, we'll try to fit them in. So I want to talk about, and I think this is a good way to kind of segue from everything we've talked about, is how has eConsults impacted the expectations for your patients and or your members? What are you seeing? And I think we've commented on this a little bit, but I'd like to drill down on it a little bit more. So I thought what I'd do is start with Dr. Khan.
Thank you. I can certainly comment from the health plan perspective. The feedback we get is mostly through our provider network on how it has helped them. As I had mentioned before, those who are utilizing eConsult have had an easier conduit to getting specialty care, especially as we now enter into winter months, and the threat is looming once again of lockdowns and potentially, hopefully not, but potentially clinics limiting their hours. So the feedback has been that it continues to provide a channel to be able to care for patients. And the data that we get back, we meet quarterly with your organization, is telling. And we look at things like, in what percentage of cases has the eConsult either changed your clinical plan, the care plan that you were planning to, you had developed, or in what percentage of cases do you think this consult has avoided a face-to-face visit? And the numbers are pretty high. We see numbers somewhere between 60 and 80% month over month, where it's changed the care plan and or avoided a face-to-face. And in the setting of COVID, that's huge. That's one more patient, one more member who was able to get care, who otherwise may not have been able to get care, because we're just not entirely certain who is totally set up on traditional telehealth and who's not set up on traditional telehealth. That's something that's ongoing, and certainly the state and the Fed is expecting us to know that. But as we figure out who has telehealth capabilities and who doesn't, we know that this is a resource available that's been on all along.
Fantastic. Thank you. Alexa, any comment?
Absolutely. So from a WellBe Health perspective, when COVID hit earlier this year, we very quickly shifted to a remote model of care to support our vulnerable elderly. And I think there was some time that there was a bit of uncertainty about what that actually would look like in the access challenges we expected to encounter. And the great thing about having eConsult connectivity already within the organization allowed us to continue to deliver care for our participants. And so the expectation from a participant perspective is that they were going to continue to receive care through the WellBe Health PACE primary care home, which I think is wonderful, in that there maybe was not a huge difference in the care they were receiving prior, except that it might have been in a remote format. WellBe Health did a very unique thing in that we deployed tablets that are elderly friendly or technology friendly to folks across the organization, so that our clinicians could continue to communicate and work with these participants across the continuum of care. And so having eConsult enabledness allowed us to, and our clinicians, to continue to seek that support and then deliver it via the tablet device. So of course, Dr. Robinson will comment as well, but my perspective is that our participants continue to receive the care, and that alone just continued the expectation around PACE providing care across a pandemic environment, across the sort of tenure of an individual within our organization once they've joined.
So Alexa, in many ways, it's helping that brand, that PACE brand, correct?
Absolutely, yes.
Awesome. Dr. Robinson, anything you would add to that?
Yeah, I think to add would be, again, on the communication side with participants. So there's often this perception in healthcare that, to see the provider, to see the specialist is to get the care that you actually, are supposed to get, like you're getting the best care that way. And so it's very easy to get caught up, as a patient or participant in our scenario, to say, okay, well, I didn't see anybody. Why, how did you get all this information? How can I trust this? Or it's just less comforting potentially. But one of the things that I found, again, as a provider, is just that communication with the participant, saying very openly, we're going to be able to get you this answer for your heart-related question right away, and you won't have to wait, and you won't have to go anywhere, and you're still going to get it from a specialist. I think that's really helpful to kind of brand that up front, or just kind of put that up front to them, so that they're not wondering, oh, did they just make up this information? Did they just stall and then come up with an answer like a week or two later for me when I saw them next? So it's actually really helpful to do that, to just tell them up front, I'm going to get this information from a specialist at, a prestigious institution who knows exactly how to handle this, and you won't have to leave your home for me to be able to get an answer for you. I think that's been really helpful, and as a result, very few people have actually asked. Actually, 0 people, I should say, have actually asked to see an in-person consultant after my having put in eConsults that that recommended that we can just keep all the care in the primary care office. So I think that's really important to just put that information up front and then set the expectations, and participants and patients will really just trust you and go along with it as long as you present it in a trustworthy fashion.
Fantastic. Thank you.
Just one additional thing to add to the trustworthiness piece Dr. Robinson hit on. I think that's really crucial in expanding the abilities of our clinicians to offer these recommendations or carry through on these recommendations from eConsult specialists does continue to build trust within our participant community around the adeptness of our providers, no matter what level they may be. So I think that's really been key, especially in the face of a pandemic and the uncertainty around that, and being homebound, which is, maybe great in the initial term, can be very lonely over the course of time and grappling with a number of other social determinant challenges. And so I think that trustworthiness with the clinician at your PACE organization is very key. And again, eConsult helps to drive that and that branding piece around that.
Thank you. And I think to all of your points, as we're thinking about COVID, and we're now seeing that the pandemic is kind of having a rise in the country across many states right now, you've all touched on something that I think is really important to highlight, which is the virtual care capability. So if I am a provider and I am, primary care, and I'm taking care of this patient, and I'm doing this through a telehealth program, whatever it is, maybe I'm FaceTiming, maybe I'm using Zoom, whatever I'm doing, the ability to expand now my care capabilities right out to that specialty piece and back without having to have my members with chronic conditions, comorbid conditions, elderly, risk themselves to additional exposures, because I can now do that in this setting. That's what I'm hearing from all of you. Any additional comments you would make on that?
Yeah, I'll make a quick comment. I think we've been highlighting that eConsults and just telehealth, maybe in general, really is a great resource for the underserved, for the elderly, et cetera. But I think, make no mistake about it, it is a significant resource also for those who just don't want to waste their time. And to be frank, I've got colleagues who are a lot younger than I am, and the perspective on delivery of healthcare is very different. It's very personalized, but it's also generational. So there is a large cohort of non-Medicaid, they're commercial insured, who don't want to spend days going to see a provider, going to see a specialist, et cetera. They want it all. They want it fairly quickly. They want it through technology. And eConsult is one of those. Does it completely replace telehealth? Not necessarily. It is adjunctive to telehealth. They kind of run to a video visit per se. But it is an option, and it does save time. It saves resource, and for many consumers, it provides that convenience of being able to get all your care under one roof, especially if you have confidence. If that person has confidence in their primary care provider, it really makes things very convenient. So it's not just a solution for Medicaid or for Medicare duals or for rural. it really has a value proposition in the commercial space as well, in my opinion, because there is a significant hunger for that as well.
Agreed. And I think we also see that in that commercial space, you're looking at a lower, if there's any cost sharing, you're certainly looking at a lower cost sharing, discussion there as well. One of the things, we're getting close towards the end of time, so I wanted to open up for questions that we might have from our audience. Doug, do we have any questions on chat, or would folks like to ask questions?
Couple quick ones. Will you have time to touch quickly on cost for the program and what cost savings have been seen in an organization?
Okay, so yes, let's talk about that. And did we have another question as well?
There is the goal to eliminate specialist visits or reduce the number of specialist visits, or both?
And I think they go hand in hand, correct? So if we're able to reduce the number of specialty visits, which is the goal, is to replicate or replace these specialty visits using eConsults, then we would see direct cost savings. But let me turn it over to the panelists. Who would like to start? Dr. Robinson, would you like to comment on cost savings that you've seen and the reduction in specialty visits?
Yeah, I mean, I know for a fact that we were reducing the specialty visits. I think that goes kind of without saying. We'd like to do a little bit more, right? So we're a young organization. We've been around for a couple of years in terms of our first PACE center that's opened. In terms of our work with ARISTA MD, it's been less than that. So we're still working on having our providers think about it more actively, right? Because not everyone has come from an environment where this is accessible or even promoted, even if it is accessible. But I can say for a fact that I've definitely had, in my own experience, numerous repeated consults eliminated. I've had good questions answered, summarily right from the get-go, and I didn't have to send someone out to get, see orthopedics the first time, get the X-ray, see them a second time, see what their mobility is like, see them a third time based on the recommendations, right? Like I've seen it happen. I can think of all these different, patient scenarios where that's happened. So, it's, we don't want to eliminate in-person consults because there are just some times where a specialist's examination is better than mine, right? I wish I had a perfect neuro exam, but a neurologist should be better at that than I am. And there are times when that's going to be just the right answer. But a lot of the time, right, especially as a generalist, right, I always had like the 90-10 rule or 10-90 rule, like, but 90% of the time you can, in the primary care office address what's happening, and then the 10% you'll end up having to send out, and those are the more 10% more complex folks. This might extend that a little bit, but even still, that 90% of the time you might be able to get that extra reassurance from cardiology or endocrinology or whomever it may be.
Awesome, thank you. And I know we have like 2 minutes to the very end. This has been such a great conversation. Thanks to our panelists for all of the input they've provided. I know there's probably additional questions, and what I would say is we will answer any questions that we weren't able to address on our panel. If you are willing to share your email address, we can come back to you with those, and also provide you with a copy of the recording. In the next 1 minute, so really quick, I'd like to do a quick round robin and just have one, final sentence to sum up what we've discussed today. And Dr. Robinson, if we can start with you.
Yeah, I think one sentence. See if I can do this. I'll keep it narrow from the provider's perspective, so I can leave it open for other folks. So I would say just provider training on this is going to be super crucial to any organization that adopts it. It's not intuitive for everybody. So you'll have to reinforce it. You'll have to coach them on how to appropriately send eConsults. And with that, you will see a reduction in utilization, higher quality consults. People will be satisfied on both sides of the care, spectrum, right?
Awesome, thank you. Alexa.
Sure. So Dr. Robinson hit some of it. So from a utilization perspective, I think it helps us really hone in on what the right utilization is for our specific population. So we've talked about over and under utilization, especially in the PACE world for an elderly population that is typically more acute or has other challenges we're grappling with. It really helps us hone in on that right utilization and appropriate cost of care. And so I think that is a key takeaway. And for us, of course, sort of allowing PACE to expand as a primary care home for our individuals, the breadth of services that we can offer to them through that primary care home versus referring to an external network in a more traditional capacity.
Fantastic. And Dr. Khan?
I'll end with this. If you're on the payer side, have the conversation with your larger groups about the value proposition and the needed clinical leadership. I think eConsults are here to stay, along with the other telehealth modalities.
Awesome. Well, thank you all of our panelists. We want to thank everyone in the audience as well. Again, we will answer any of the questions that we weren't able to touch on today, but we do appreciate your input, and thank you for joining us today. Thank you, my panelists, for participating. It's been a great discussion.
It's been a pleasure. Thank you.
Have a great week, everyone.